Hi, everyone, and welcome to the American Ambulance EMS podcast. I'm Dr. Danielle Campaign, American Ambulance's medical director. I'm here with one of our awesome co-hosts, Dr. Sajjan Bhakta. And today we're going to be talking about imminent delivery. Let's go through and discuss kind of the basics of labor, just kind of talk through our audience, like how to recognize how much time you have. Let's start out with the stages of labor. So first stage, that's when the contractions are about 3 to 5 minutes apart for at least an hour. This occurs until the cervix is completely dilated to about 10 centimeters. This typically lasts 4 to 5 hours, and faster for women who have delivered previously. And they go through all the stages of labor faster since their body's kind of done this a bunch of times. Then we're going to the second stage. It's the time from complete cervical dilation until the baby is delivered. That typically takes 20 to 30 minutes. In Mindy's case, it sounds like it was like less than 5 minutes. So that can definitely be variable. So if you had a patient who has contractions 3 to 5 minutes apart for more than 3 hours, be prepared for delivery, especially if this is not their first baby. So the third stage is the time from delivery of the fetus until delivery of the placenta. This typically takes less than 30 minutes. So you've already clamped the cord. You're going to leave that cord alone, let it do its thing. So hopefully within that 30 minutes, you've arrived at the hospital and you have other resources to help with the delivery of the placenta.
Questions that I kind of came up with that I think are really important for history taking. First is, how many babies are there? Are you pregnant with twins or triplets? Do you know that? Have you given birth before? Again, that speeds up the timing of labor. How far along are you, or when are you due? And then any complications with this pregnancy? And then lastly, any medical problems for the mom? So those are kind of 5 questions that I think are really important to know as you're delivering the baby, give you a sense of how much time you have, how many babies there are, and then any major medical problems. For example, if the mom has a history of a C-section and they're attempting to deliver vaginally now, that places them at a very high risk for something like a uterine rupture, which can be devastating. And it's good to know that ahead of time. And then assessing gestational age, babies who are born really at a gestational age less than 22 weeks have a really poor chance of surviving. But babies born between 26 and 40 weeks have a high likelihood of survival. And then, of course, it's always good to know about any potential bleeding disorders or diabetes, as you mentioned, Mindy. Bleeding disorders, again, postpartum hemorrhage is a major complication that we want to watch out for. And then diabetes, as you mentioned, can cause macrosomia, which is when the baby is a little larger than we want them to be, or have problems with their blood sugar as soon as they're born. So I think you did a great job asking a lot of those questions.
Now we're going to jump to management. So Mindy, you brought this up when you look down, like, what do you see? Do you see that bulging bag of waters? Do you see a foot? Do you see something like, what's the presenting part? Can you kind of walk us through kind of like what's going on in your head during those 30 seconds of looking at the perineum? What are you looking for? What are things you're hoping you don't see or hoping you do see?
When I look down there, I'm seeing, first thing, is my patient crowning? Is there a head coming out? If there's not, is there a cord hanging out? That's a big thing I always look for. Cord, bulging bag of waters, so maybe the baby's not all the way engaged into that canal. Bleeding, color of the leaking fluid. Another important thing when assessing the bag of waters and leaking fluid from a patient, besides the amount and color, is smell. Does it have a really bad smell, or does it not smell at all? A really bad smell can be a sign of chorea, which is an infection in the amniotic fluid, isn't it? And it's important to tell the labor and delivery nurses and doctors when you get there about that, because it increases that baby's risk of sepsis and the mom having infection as well.
So color of the leaking fluid, like we want to know if there's been meconium, right? If the baby has pooped inside the uterus. And so in your mind, if you see a color to green or a dark color, you would say, oh no, they might have lung problems, right? When they come out. So maybe you get your bag ready, which you already have ready to bag this baby, or you'd be more prepared for that. Then you mentioned the cord presenting. Tell me more about that. And what would you do if there was a cord presenting at the perineum?
Definitely, if there was a cord presenting, it would be rapid transport. Would also feel the cord if it's pulsating. We just put our patient in a position to continue it to be pulsating. If it's not, it's the only time we stick our hand in a vagina and lift the baby's head up and move it around until we feel that cord pulsating, and we don't pull our hand out until
right. So
we
this
get
is
to the hospital.
An emergency.
Yeah.
it's a umbilical cord prolapse. And so if you can imagine, the cord comes first and then the head pushes on it. So sadly, the baby's head is cutting off their own blood supply. So you putting that hand in the vagina and lifting that presenting part off is kind of like stopping the flow of labor, just so that they can have that cord still bring blood supply to the baby. And remember, you stay with that hand inside the vagina all the way to the operating room, right? And then they're going to cut that baby out for a C-section, and then you get to remove your hand. So a very stressful job. I've seen only a couple of medics come through doing that, and I always feel bad for them because it's very ergonomically hard for you, right? You're on the gurney, you're bent over, and you're going long distances. But I mean, you are the thing that's saving that baby's life. So it's really important. Let's touch on some potential complications like breech presentation. So Mindy, you want to talk to us about what a breech would look like if you're looking at the perineum?
So a breech delivery would be a baby presenting crowning with the baby's bottom or a foot or both feet.
And when you see that, I want like bells to go off in your head, like high risk delivery. I know 30 years ago, they delivered these all the time and it was like not a big deal. But nowadays it seems like in modern medicine, we really try not to go through this. And these patients would almost always have a C-section if they knew that they had a breech presentation, the baby hadn't turned. So you probably would want to transport these patients code 3, like with lights and sirens, because you don't want to attempt to pull the baby out. So worst possible scenario is the body comes out, right? So you have, say, the butt came out first, or a footling and then a butt, and then now the head is not delivered. So now it's the opposite we were talking about before. So the whole body's out but the head. And so you worry about the baby suffocating because the body is out, but the baby can't breathe. Usually if the head hasn't delivered in 3 to 5 minutes, you worry about them suffocating. So one thing that we do in the hospital is you're going to make a V shape with your second and third fingers and kind of slide the fingers over the baby's chin with your fingertips on the cheeks and try to create a space for air to reach the baby. You're not going to rock the baby's head back and not pull on the baby's head. And then you're trying to flex the baby's neck to try to bring that neck in so you can deliver it. So remember, usually the head gets kind of stuck behind the pubic bone. So you're trying to bring that head down, always head to chin, to bring it down to try to deliver these babies.
All right, so let's imagine we've assessed the patient and we've placed them on the proper oxygen and vital sign monitoring systems, and we look at the perineum and we see the head crowning. So we're going to prepare for our delivery. We have all of our equipment like we talked about, not only for mom, but also for the baby that comes out. The goal is to have a controlled delivery. Mindy mentioned that, she placed a hand on the baby's head to prevent the baby from shooting out really rapidly. Mom pushing too hard or not pushing hard enough can both cause complications. We want a controlled delivery where it's nice and smooth and not too rapid and not too slow. Moms have a tendency to hold their breath and really bear down when they feel those contractions. So one thing that's often mentioned to moms is to just have them pant or breathe through the contractions. And that helps them give a little more constant, steady push as opposed to holding their breath and bearing down. Mindy, what do you think is the best position in an ambulance during transport? How do you position the mom if you find that baby is coming out, that you see crowning?
If she's in labor, we would have her seated, hips flexed, knees bent. Probably the most comfortable position to deliver a baby in an ambulance. And then if they weren't in labor, then that's when we would have them rotated to their left side.
And we rotate them on their left side because the baby is large enough and can collapse the mom's IVC and cause circulation problems for the mom. So if the mom is in labor, we're going to position her in that lithotomy position, bring her knees almost up to her chest, hips nice flexed, and open up that perineum so that the baby has the most room to come out. So the next steps, after we position the patient, we see the baby is crowning and we're going to deliver the baby. There are many motions that the baby goes through as it's coming out. Really, I think the most simple way that we guide the delivery is in 3 parts. 1 is delivering the head, 2 is delivering the anterior shoulder, and then 3 is delivering the posterior shoulder. And once you get both shoulders out, then the rest of the baby usually comes out pretty smoothly. So hopefully the presenting part is the baby's head, and most commonly it is face down, but just like in Mindy's case, there can be times where it's face up. You want to put gentle pressure with your just fingertips on the baby's head, again, just to control how quickly it's coming out. And we never want to pull on the head or extend the head backwards. If anything, we want to keep the baby's head in a flexed position. That means the chin to the chest, and allow the chin to eventually be delivered. Once the head is delivered, the baby will typically start to turn to lay on its side. This is when you have a chance to look for an umbilical cord that can be looped around the baby's neck. And if you see this, you want to try and gently lift the cord up and around the baby's head and try and untangle the baby.
But I have to say, I've done this twice in the ER, and they've both had cords, and it is really hard to untangle that cord. I don't know, Mindy, if that's your experience too from working on L&D, that sometimes those cords are so tight. So kind of be patient. Sometimes as the next push comes out, the cord kind of untangles itself. So don't be in a hurry to fix that cord, but if you can, gently remove it, try to.
Cords are slightly stretchy, so a lot of times it's easy just to stick your finger under the cord and kind of slide it around to get it loosened to unravel it from their neck. It also depends on how many times it's wrapped around. Triple nuchal can be a lot more difficult to untangle than just a single.
Correct.
Definitely. So once we've gotten past the chin and the neck, and we start working on the shoulders. And so the next goal is the anterior shoulder. And we want to try and deliver the shoulder by guiding the head slightly down to the floor or down to the gurney. And this allows the shoulder furthest from the ground or the gurney to deliver. And as soon as the first shoulder is visible, you gently guide the head in the opposite direction, upwards, and that allows the posterior shoulder to deliver. Now, this can be an area that develops many complications, and that's when the shoulders are not able to be delivered. That's called shoulder dystocia, and that is something that we consider a complication and emergency even in the hospital. So if you're having difficulties with this, then just another reason to try and get to the hospital as soon as possible.
As you can imagine, this position, just to kind of reorient everybody, you have a head out, so a head at the perineum, usually just neck and head out. The shoulders are stuck behind the pubic bone, right? So they're stuck inside. And so the baby's kind of this precarious position. It cannot breathe very well because it's compressed in the vaginal cavity. But at the same time, its head is out. So you can see this kind of blue head. You're trying to suction baby, but you're trying to really deliver that shoulder. So maybe Sajin or Mindy talk about some strategies that you would use to help deliver that stuck shoulder.
One position that is often helpful is, I believe it's called McRoberts. And when I've seen this in the past, they will lay the patient completely supine and pull her knees as far up as they can go, just really opening up that canal to try to get that baby out with a little bit of pressure on the suprapubic area.
Yeah, exactly. That's 100% right. So in the hospital, we have a lot of extra bodies to help us. I know in the back of the ambulance, it's just you, but we would have one person on each leg, like really pushing those knees flexed back as far as they can. Like you said, to open up that pelvis. You have someone put suprapubic pressure, so you're trying to push down on that shoulder, trying to give yourself as wide of a birth canal as you can to get those shoulders out. And like with your baby that you discussed in this case, it might be a big baby of a diabetic mom and have really giant shoulders and really have a hard time passing.
Yeah, that's great. And once you've delivered the shoulders, like I said, typically the rest of the baby comes out pretty smoothly. Just make sure you have your gloves on and you have towels so that it's not too slippery and you can catch the baby. The way you position yourself to handle the baby appropriately is typically you want to have one hand cradling the neck and the back of the head, and the other hand guiding the baby's bottom and the legs. And so you can hold them with two hands. And after you feel like you're secure, then you can cradle the baby with one arm if that's possible. And then you dry the baby, and we assess the baby real quick and hopefully get our baby over to mom as soon as possible.
Let's talk about the three things you're going to check really quick when assessing a neonate. So it just popped out. It's nice and slimy. You're going to look at, are they term, right? We talked about that. How's their tone, and are they crying? Like those are the big three, right? Term, tone, and crying. And so full term, right? They're going to look big. Hopefully they're pretty chubby. They're going to have vigorous tone, meaning moving arms and legs, not floppy. And a crying neonate doesn't mean they need any resuscitation, right? They're crying. They're doing everything they're supposed to. We want them to scream as loud as they can. Things that would concern you would be a weak cry or a whimper or just silence. So, Parents listening love it when their kids are quiet, but we don't want the baby to be quiet. We want that baby to be loud and crying and ear-piercing screams if possible.
So as long as the baby meets those 3 criteria of the term, tone, and crying, then we can dry the baby, stimulate the baby with the towels, and then we want to place the baby on the mother's chest as soon as possible. That skin-to-skin contact is important for a variety of reasons.
What about delayed cord clamping? Some people talk about clamping the cord right away. People talk about delayed. What's the latest evidence on that?
So the data shows that delaying cord clamping for at least 60 seconds after delivery improves outcomes for the neonates, gives them a little more oxygen and circulation prior to being independent. And typically in the hospital, we wait a minute, 2 minutes. Unless there's a complication that the baby needs to be resuscitated, we really allow for 1 to 2 minutes of delay between delivery of the baby and clamping the cord and eventually cutting it. And once we've clamped the cord and cut it, we are going to expect delivery of the placenta. Again, this can take up to 30 minutes. We don't want to tug or pull on the umbilical cord to try and deliver the placenta. This can cause incomplete removal or trauma to the uterus.
Right, so the goal would just be like natural delivery of this placenta, which can take up to 30 minutes or even longer. By that time, you'd be at a receiving facility, and then the OB would be managing that.
Very important to try and prevent severe postpartum hemorrhage. According to the WHO, risk of maternal mortality secondary to hemorrhage is 1 in 1,000. We'd like to make that 0, considering how many deliveries occur each day. And there are a couple things that we can do to try and prevent the uterine atony or complications that we can see that can cause the hemorrhage.
And uterine atony, just for everybody, is a fancy term for just a floppy uterus, right? So uterus is a big old muscle. It's stretched out to hold this baby. It's trying to contract down to deliver this baby. And then most of them naturally just contract down, and that helps pinch off the arteries and veins that are bleeding. So postpartum blood loss gets very small. But if it stays kind of like a big floppy uterus, then it doesn't squeeze down, and they can just bleed quite a bit. And so when you're seeing brisk, bright red blood come from the vagina, that uterine massage, fundal massage can really help that uterus kind of clamp down.
Yeah, you really want to try to find the top of that, the fundus of the uterus, typically around the belly button, and really use a towel and be vigorous with your massage and feel it contracting and clamping down. And hopefully that stops the bleeding. And then Mindy mentioned with precipitous deliveries, we have to be careful of large lacerations in the perineum. So if you see a spot in the vaginal canal that's briskly bleeding, just like any other source of bleeding, you want to place pressure on that area until we can figure out some definitive management at the hospital.
It is important to note that once the baby has delivered, you now have 2 patients under your care. So for documentation-wise, you need to have 2 PCRs, 2 patient care reports, documenting what you see on the baby, and then on the mom's PCR, how you're assessing mom. And so there should be 2 PCRs with this call. Right, so let's wrap this up with some great take-home points. If no one was really listening as they were playing this in their car on the ride home and they only remembered one thing from today's podcast, Mindy, what do you want your colleagues to remember?
Anytime you deliver a baby, every single newborn warmth and temperature control is extremely important. Whether you have that baby on mom's chest, the baby still needs to be covered, tucked in, kept warm with their head covered. Babies lose a lot of heat from their heads. So keep your baby warm. Great point. Sajin.
I think it's just important to remember that you have 2 patients. It's easy to focus on the mom first and then the baby and then forget about mom later. Remember, you have 2 patients the entire time. Be prepared to resuscitate and to assist both patients.
All right, and my take-home point is be prepared to deliver at all times. So when the mom says, I'm full term or I'm not full term or I feel like I'm in labor, just get that kid out, be ready, know that baby could come and be ready for that imminent delivery. So thanks everyone for all you do out there, and thanks for listening.
Thank you.
Thank you.